So welcome to Pediatrics Grand Rounds, and today we'll be talking about approach to red urine, and especially we'll talk about nephritic syndrome. So I welcome you all. So by the time people join, we'll keep on talking. So all of you, the topic of the day is red urine and nephritic syndrome. My name is Dr. Siddharth Sethi. I'm the pediatrics faculty and head of pediatric nephrology at this hospital since last 10 years. So we'll wait for everyone because we'll wait for a minute and then we'll start. Okay, let's start. And now will be first our topic of the day is approach to red urine, and then I'll take you from there, and then I'll take you to a case of nephritic syndrome. Okay, so let's first talk about, so what we'll do today in all of these grand rounds is, as all of you are aware, that we talk about clinical situations. So today I'll be sharing with you at least 4 clinical cases. Okay, I'll show you 4 clinical representative cases, and they are not like imaginary cases. These are all cases which I have seen in my practice, and I want to bring your attention to some important points about these cases. So first of all, let's start with a child with red urine. What should be your first test in a child with red urine? So all of you, your first test in a child with red urine, before even going for test, you should ask a history. History is important. Why is history important? Because there are many drugs which can cause red urine, especially rifampicin, phenolphthalein. This may be, this child had taken first time in his life, he took some beetroot. Sometimes the beetroot can cause red urine. Okay, so it could be even beetroot. So if this history is negative, so if there is no, if this history is absent, now all of you, you should look for RBCs in the urine. RBCs. If RBCs are positive, that's called hematuria. If RBCs are positive, that's called hematuria. If RBCs are absent, can anyone tell me what can this be? A child has red urine, okay, but the RBCs are not there. What can this be? Then you should always look for heme. And students, I would like to tell you that in our labs, in our hospitals, all of us have a heuristic. That's called a multi-stick. In that multi-stick, it looks for heme, it looks for WBCs, protein. So it is a multi-sticks. So heme can be positive in hemoglobinuria. In hemoglobinuria. In myoglobinuria. In myoglobinuria. Okay, hemoglobinuria, for example, you have a baby with G6PD deficiency, and as all of you are aware, if you give anti-malarials, some antibiotics to a child who is G6PD deficient, that patient can have hemolysis. So in G6PD deficiency, if you give some anti-malarials, antibiotics, these patients can have hemolysis. Hemoglobinuria is done, but what about myoglobinuria? Sometimes a child or a adolescent has done massive exercise. I live in Gurgaon, and very commonly I see these children that in Gurgaon we have half marathons. Have you heard about marathons, half marathons, and Delhi triathlon. So what are these? These are, marathons for which you have to practice. I remember we recently had a 16-year-old, and he just came to India, and he ran a marathon in Gurgaon, and in front of my hospital he collapsed because he did violent exercise, and because of violent exercise he got rhabdomyolysis. Rhabdomyolysis leads to myoglobinuria. I live in Haryana. Haryana is the state of, uh, all the sports, as all of you are aware of. So recently, one boy in my city of Gurgaon had he had a bet that he will do 300 push-ups. So he had a bet to do 300 push-ups. तो शर्त तो वो जीत गया, पर किडनी वो हार गया. So because of violent exercise, he got such a big myoglobinuria, which led to acute tubular necrosis. So both of these are endogenous toxins which can cause acute tubular necrosis in the kidneys. So it can cause acute tubular necrosis in the kidneys. Okay, so these are endogenous toxins, heme, myoglobin. They are endogenous toxins which can cause tubular necrosis. Now let me take you guys to this aspect of RBCs. If RBCs are there, that's called hematuria. Okay, so let's take you to hematuria and then we'll go from there. So if you have a patient who has hematuria, first of all, you need to know, how do you define hematuria? How do you define hematuria? Okay, Santosh, those were causes of red urine. Welcome, guys. So how do you define hematuria? Hematuria is defined as more than 5 RBCs per high power field on a centrifuge urine. On a centrifuge urine, if you have more than 5 RBCs per high power field. So students, what I want all of you to, if you have, I know we have some undergraduates here, we have some postgraduates here, and even we have PG aspirants here in the class. So students, what I want you to do is, in your night duties, whether you are UG or PG, please don't sleep at night. In your night duties, if you have a patient with some kidney problem, please take the urine, go to the lab, centrifuge the urine, and examine the sediment. And I would like to tell you all that, that what I did during my PG life is that if we had a patient with anemia, I would go to the lab, I would stain the smear, and I would look at whether the RBCs are microcytic hypochromic, macrocytic anemia. So this is your job. जब नाइट ड्यूटी करोगे तो प्लीज go to the lab, do it yourself. Okay, so remember that. So now hematuria is of two types. It can be glomerular, so it means these RBCs are coming from the kidneys, or it can be extra glomerular, which means RBCs are not coming from the kidneys, they're coming from somewhere else. Okay, so it's glomerular or extra glomerular. Now, how do you differentiate? Anyone? I want some interaction in the class. Okay, so I don't want you guys to just listen here. I want you to be interactive. So can anyone tell me what are the features of glomerular hematuria? What are the features of glomerular hematuria? How do you differentiate? Number one, cola urine. Cola urine is glomerular, while bright red urine is extra glomerular. So when the hemoglobin is passing through the tubules, it's digested. So on the way in the tubules, the hemoglobin is digested. So cola urine is glomerular. Glomerular is painless, while extraglomerular is painful. Glomerular may be associated with proteinuria. It may be associated with proteinuria, and very well said by Dr. Yashika, Dr. Gupta, Dr. Deep. Dysmorphic RBCs. Dysmorphic RBCs. टूटे टूटे RBCs. So टूटे टूटे RBCs किस में मिलेंगे? Glomerular में. Because when these RBCs, nephron is so complex. It's very difficult to make an artificial kidney. Because the nephron is so complex, every segment of the nephron has different pH. And when these RBCs pass through the nephron, they're lysed. They undergo a osmolar damage. So RBCs undergo osmolar damage. Okay? Osmolar damage. So that's why, it is very difficult to make an artificial kidney. It is easy to make an artificial pacemaker because heart का काम क्या है? दिल सिर्फ धड़कता है. But kidney has so many functions which cannot be replicated by a machine. On the other hand, isomorphic, they are normal looking RBCs. Okay, Dr. Pallavi, welcome to the class. We are talking about an approach to a child with red urine, and from there I'll take you to nephritic syndrome. Okay, so that's most important point about differentiating between these. Now, what are the most important causes? And I would start from extraglomerular. Red urine, the most common cause of red urine is actually UTI. So if someone asks you, what is the most common cause of red urine? So please say UTI. So UTI is the most common cause of red urine. Okay? So remember that. Okay, that's very important. Okay? Other causes can be hemorrhagic cystitis. Let's write hemorrhagic cystitis first. Cystitis, hemorrhagic cystitis. Okay? Hemorrhagic cystitis, which can be, all of you know, it can be drug related. For example, cyclophosphamide, or it can be viral. Very commonly, I do clinics in multiple cities of our country, and very commonly I see when I do clinics, I see many children coming to me with fever and red urine consecutively. How can a lot of children in the same community have fever and red urine? It could be a virus like adenovirus. It's very common that adenovirus can cause a hemorrhagic cystitis. Okay? So remember, UTI is the most common cause of hematuria in children. Now, other causes of hematuria, let's look at the glomerular causes. IgA nephropathy, MPGN. MPGN is membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis. Post-streptococcal glomerulonephritis. Okay, membranoproliferative glomerulonephritis, post-streptococcal glomerulonephritis. And then there can be some syndromes like Alport syndrome. Like Alport syndrome. Okay. Okay, can we go to the next page, students? So our topic of the day, guys, is a nephritic syndrome. And I want all of you to know what is nephritic syndrome. So what we'll do is, I'll take you to a case, and this is a typical case which I see every week in Haryana, and I'll share with you, students, that I joined private practice, 10 years back. And when I joined private practice, I thought it will be very easy, I'll just see, simple fever, vaccination, things will be very easy. But then I realized that in my hospital, I don't see simple patients. Patients only come to you know, a costly hospital when they are in trouble. So I only see serious patients. I don't see simple guys. So I had a patient here who came to me, a 8-year-old boy with swelling for the last 5 days all over the body, smoky urine. Urine is smoky, cola colored, decreased urine output. There's no past history, no history of fever. So you should ask a history of fever to look for any past, sore throat, rash, joint pains. Now there was a history of pyoderma on his scalp, and you can see his pyoderma on the scalp 4 weeks back. Okay, so there's a history of pyoderma 4 weeks back. Okay, so students, whenever you have a case presentation after the history, you should be able to summarize and have something in your mind. So can anyone tell me what comes in your mind with this history? Anyone in the class, can you tell me what comes in your mind with this history? Swelling, smoky urine, decreased urine output, history of pyoderma 4 weeks back. So what comes into your mind, students? So something you feel like maybe this patient had a history of streptococcal pyoderma, and now he has, of course, he has glomerular hematuria. So he has glomerulonephritis. You're right. So I'll take you first to the history, and now examination. On examination, he had edema. There was no pallor. His blood pressure was 140/96. Students, very soon maybe I'll take a grand round on hypertension. And I would like to share with you, students, what is hypertension? Hypertension in children. What is hypertension? Hypertension in children is defined as a blood pressure more than the 95th percentile. So if we have blood pressure charts, and if the blood pressure is more than the 95th percentile, so class के आखिरी 5 बच्चे for age and sex, or simple, a blood pressure more than 130/80 for a child more than 13 years is hypertension. So according to the American Academy of Pediatrics, 130/80 तो 13-year-old के लिए भी hypertension है. This is a 8-year-old. So I told you that 130/80 is hypertension even for a 13-year-old according to the American Academy of Pediatrics. Okay, I'll tell you in a coming grand round later on that the adult guidelines changed in 2018. Adult guidelines said blood pressure or hypertension is more than 130/80. So we also change, in pediatrics also, as per adults, for more than 13-year-old, I say 130/80. Coming back. So this child is clearly hypertensive edematous. Okay. On investigations, his creatinine is high, 1.2. Normally creatinine should be less than 1 in an adolescent. He has proteinuria, full of RBCs. Urine is full of RBCs. C3 is low. ASO is high, and even anti-DNase B is also high. So basically, we looked at ASO. Why did we look at ASO? ASO, anti-streptolizin O, and anti-DNase B are streptococcal antigens. So we are looking for evidence of a past streptococcal infection. Group A, beta hemolytic streptococcal infection. So there is evidence of group A beta hemolytic streptococcal infection. So this child definitely has post streptococcal glomerulonephritis. Okay, so he has nephritic picture, nephritis with streptococcal evidence. So it's post streptococcal. So I would say a more complete diagnosis here, instead of post infectious, I would say it's post streptococcal, because I also got evidence of streptococcal infection. So my diagnosis is post streptococcal glomerulonephritis. And how do you manage this case? Can anyone tell me what will be the antihypertensive of choice in this case? What will be the antihypertensive of choice in this case? Furosemide. So remember students, in glomerulonephritis, the hypertension is because of sodium and water retention. So the antihypertensive of choice here is furosemide. It's not ACE inhibitor, it's not calcium channel blocker, it's furosemide here. So I will restrict fluids here. I'll give him furosemide, manage his hypertension, okay? And over the next 7 days, this child's BP improved, his swelling improved, and I sent him home and I discharged him. Okay, Samia, you can, Dr. Samia, you can look at the investigations. So, Dr. Neeraj, ASO actually more than 200 is high. However, Dr. Neeraj, I would say we usually look at rising ASO. Rising ASO titer is better. And Dr. Neeraj, I would like to highlight two things here. Number one, if someone has sore throat, history of sore throat, get ASO. If someone has history of pyoderma, get anti-DNase B. Okay, Dr. Neeraj? So usually in sore throat, ASO is high. In pyoderma, anti-DNase B is high. Okay? So remember this. So the diagnosis we have told you. Now let's talk about what is nephritic syndrome. So I would like to highlight here, what is nephritic syndrome? So remember students, nephritic syndrome is defined as abrupt onset. This is very important because you will see this patient every week in your hospital and you will say, "Yare, ye to nephrotic hai." No, nephritic has abrupt onset, and this triad. What is this triad? Hematuria, hypertension, and proteinuria. So this triad, hematuria, gross or microscopic, hypertension is very important, and proteinuria. So hematuria, hypertension, and proteinuria. Okay, so that's the classic triad of nephritic syndrome. This is not nephrotic. So nephrotic may, please remember, in nephrotic syndrome, we'll take a grand round on nephrotic also someday. In nephrotic syndrome, remember that hypertension in children is rare. Hypertension in children will be rare, and so will be hematuria. Gross hematuria, hypertension will be rare in nephrotic syndrome. तो समझ आ रहे हैं? हमने कहा nephritic has a triad of hypertension, proteinuria and hypertension, proteinuria, and hematuria. Okay, so remember that. So let's take you now to what are the causes of nephritic syndrome. So if a child, like I showed you today, that child was clearly post streptococcal. But remember, there are many other causes of nephritic syndrome. But remember, the most common cause all over the world, if a patient comes to you, at least, when I joined private practice, I thought, rheumatic fever, I thought it does not exist. I thought post streptococcal GN does not exist. But students, I will tell you, every week of my life, every week, I see one post streptococcal glomerulonephritis coming to me from North India. It's common here, at least it's common in this part of the country. So post streptococcal is the most common cause, infectious. Other causes can be some other infections causing a nephritic syndrome. You can have a non-infectious causes like a primary glomerular disorder like membranoproliferative glomerulonephritis, SLE, membranous GN, IgA nephropathy. So primary glomerular diseases, but it can be a part of multisystemic disorders also like SLE, Henoch-Schönlein purpura, vasculitis. Okay, so remember, nephritic syndrome can also occur as a part of primary glomerular disorders and multisystemic disorders like SLE, Henoch-Schönlein purpura, and vasculitis. Okay, so let's first talk about the post streptococcal glomerulonephritis, the most common post streptococcal glomerulonephritis. And this has today is a clinical grand round. So in clinical grand rounds, we also take you from the history of the disease. So way back in 1849, so it would be almost like, I don't know how many years, almost 150 years. So people knew about this almost, more than 150 years back. There was a scientist, his name was Miller, and he said that this is a albuminous and exudative urine in a scarlet fever like infection. Someone had pyoderma like scarlet fever, and his urine was having protein. But later on, it took science almost 50 years to understand that post streptococcal glomerulonephritis is because of streptococcal. So how do you define post streptococcal glomerulonephritis? It's immunologically mediated glomerular injury. It's immunologically mediated glomerular injury triggered by a non-renal infection, mostly streptococci. Okay, immunologically mediated glomerular injury triggered by a non-renal infection, most commonly streptococci. Okay, so students, remember, this is the typical presentation of post streptococcal glomerulonephritis. ये क्या है? This is pharyngitis. Or this is pyoderma. This is pharyngitis, this is pyoderma. Okay, so you have, it follows after a latent period, and I would like to highlight here, after 1 to 2 weeks of sore throat and 4 to 6 weeks of pyoderma. So it classically happens 1 to 2 weeks after pharyngitis and 4 to 6 weeks of pyoderma. Okay, so it takes almost a 1 to 2 weeks after sore throat. And what I'll do is I will keep on asking you questions. So let us make this class interactive, guys, and let us ask you a question, because we want some action in the class. Okay, so we want all of you to not keep quiet and stay here and ask questions. So all of you, here is a child, and all of you, my question to you is, a 7-year-old boy has sore throat 10 days back, and now he comes to you with edema, cola colored urine, his complements are low, C3 is low, he's hypertensive. What is your diagnosis? Anyone in the class? Abhishek, tell me the diagnosis, then I'll take you to the previous slide. Of course, after 1 to 2 weeks of sore throat, of course, all of you in the class are right today. All of you are right. Yes, you're right. This is a post classic case of post streptococcal glomerulonephritis. You're right. This is classically post streptococcal glomerulonephritis. Okay. So all of you are right. Okay. All of you are right. So let's take you to the course. What is the course of this disease? Okay. What is the course of this disease? So usually students, the course is in a typical post streptococcal glomerulonephritis. Let's look at the course. Remember, hypertension and if they have a lot of proteinuria, if they have a nephrotic range proteinuria, it usually resolves. It usually resolves in 1 to 2 weeks. It resolves. Okay. Now remember, C3 is low in post-streptococcal glomerulonephritis. C3 is low. Why? Why is C3 low? I'll show you a kidney biopsy just now. C3 is low because C3 is deposited in the kidney. So C3 is low. And C3 comes back to normal in 6 to 8 weeks. So C3 comes back to normal in 6 to 8 weeks of the illness. I would even add here that gross hematuria also resolves in 1 to 2 weeks. So I would add here gross hematuria also resolves in 1 to 2 weeks. However, remember, microscopic hematuria, if you see, some RBCs in the urine. So microscopic hematuria takes almost 6 to 12 months to normalize. So microscopic RBCs, it takes almost 6 to 12 months to normalize. Okay, so remember that. It takes 6 to 12 months to normalize. Okay, so this is what I tell to the parents every day. मैं यही कहता हूँ पेरेंट्स को कि देखो, don't look for the urine RBCs. These RBCs in the urine may take almost 6 to 12 months to normalize. It's okay. Okay. So we are not scared about some microscopic RBCs, but gross hematuria should resolve. Yes, Astha. Okay. So remember, this is a benign condition. 95% of the times it's benign. Only in 5% of these children they can go into chronic kidney disease. So only in 5% of these patients they can go into chronic kidney disease. So remember, it is a benign course mostly. It's mostly benign. So mostly we do not do a kidney biopsy. Normally we don't do a kidney biopsy. Okay. But if we do a kidney biopsy, what will we find? तो देखा आपने नॉर्मली बच्चों में हम बायोप्सी करते नहीं है ज्यादा. ओके, बट देन देर आर सम definite indications of kidney biopsy in nephritic syndrome. There are some definite indications of kidney biopsy in nephritic syndrome. So when will we do a kidney biopsy? Let's divide this into two. At onset. At onset, if a patient comes to you in renal failure, at onset he comes to you in renal failure. At onset, suppose patient has normal C3. Normal C3. Please remember, C3 is low in almost 85% of post-streptococcal glomerulonephritis. So if C3 is normal, maybe this is something else. So we may do a kidney biopsy. At the onset, if this child has secondary features, something which suggests a secondary cause, for example, he has palpable purpura. Over the shins and the buttocks. It is invasive. Kidney biopsy is invasive. So we don't normally do kidney biopsies. It's invasive. If this child has features of SLE, all of you will read about SLE. In SLE, there is malar rash, anemia, photosensitivity. So in SLE, there is a malar rash, anemia, photosensitivity, seizures. Think about a secondary cause of nephritis. Okay. Now, if after, second indication can be after 4 to 6 weeks. After 4 to 6 weeks, this child has persistent hypertension, persistent protein loss. Suppose he has persistent nephrotic range proteinuria, very high proteinuria, nephrotic range proteinuria. We'll do a kidney biopsy. And what if I say even at 8 to 12 weeks, C3 is persistently low? I told you C3 normally comes back to normal. But even after 8 to 12 weeks of the illness, suppose C3 is persistently low, I will do a kidney biopsy to find the cause. Because this can be a condition called MPGN. A very rare, however, it is sometimes rarely seen in children. It's called MPGN, membranoproliferative glomerulonephritis. Okay. So what if I do a kidney biopsy in post-streptococcal glomerulonephritis? On your screen is a typical kidney biopsy of post-streptococcal glomerulonephritis. Can you see a lobular appearance of the glomeruli? Can you see they're like lobules? So it is called lobular accentuation of the glomeruli. क्या कहते हैं इसको? Lobular accentuation of the glomeruli. So glomeruli are lobules like. There are lobules here, lobules here, lobules here. Why is it so cellular? Why are they so diffusely cellular? Because they have endothelial cell proliferation. So in the glomeruli, there are some endothelial cells inside. And then there are mesangial cells. All of you know this pinkish area within the capillary loops is called mesangium. Okay. So in the mesangium, you have lot of cells here. I can see more than 6-7 cells. So if you see a lot of mesangial and endothelial cell proliferation, that's post-streptococcal glomerulonephritis. Remember, it's a diffusely proliferative glomerulonephritis. So pathology में क्या देखा हमने? Diffuse proliferation of the endothelial cells and the mesangial cells. Okay, diffuse proliferation. And what is specific for post-streptococcal glomerulonephritis? Neutrophils. Neutrophils within the glomeruli is specific. Okay, so Neeraj, we are talking about light microscopy here. I'll take you from light microscopy to immunofluorescence. So remember, Neeraj, Santosh, Astha, neutrophils. Neutrophil infiltration in the glomeruli is very specific for post-streptococcal glomerulonephritis. Okay, neutrophil infiltration. And then on your screen here is an immunofluorescence. And can you see a starry sky? Can you see a starry sky pattern? इसको कहते हैं starry sky, starry night. It's a starry sky pattern. They are granular deposits of IgG and C3. So you can see granular deposits of IgG and C3. Okay, so all of you, why was C3 low? Because C3 got deposited in the glomeruli. And this is the classic starry sky pattern, which is granular. Remember, can you see granules? Can you see? It is not a straight line. These are more of granules here. So granular appearance is seen in post-streptococcal GN. Okay. Can anyone in the class tell me in which condition do you see linear deposits? Can anyone tell me in which condition do you see linear deposits in the glomeruli? Good-Pasteur syndrome. So remember, in Good-Pasteur syndrome, you see linear deposits. Okay, linear deposits in the glomeruli. Okay. In Good-Pasteur syndrome. No, Shubhangi, no. I'll come to your doubt, Shubhangi. In linear deposits are seen in Good-Pasteur syndrome, which is called anti-GBM disease. So remember, linear deposits of IgG-C3 are Good-Pasteur syndrome. And this is a classic electron microscopy. This is a classic electron microscopy. So all of you on your screen here this is the basement membrane. This band is basement membrane. These are the foot processes of podocytes. You can see these villi projecting here into the urinary space. Now a hump का कोई और कारण नहीं होता. There is no other cause of hump. Okay. Hump. So subepithelial humps are only seen in post-streptococcal glomerulonephritis. Okay. Okay. So remember, subepithelial humps are only seen, okay, in post-streptococcal glomerulonephritis. Okay, so remember that. So let's come back here and let's ask you an MCQ. I want all of you to be attentive in class. So all of you, I have a question for you. My question to you is, persistently low C3 is seen in all except, and I want all the participants here in the class to answer my question. Persistently low C3 is in all except. In which condition do you have a transiently low C3? Out of these conditions, in which condition do you have a transiently low C3? And all of you are right, yes. In post-streptococcal glomerulonephritis, C3 comes back to normal, it normalizes in 6 to 8 weeks. So in post streptococcal, it normalizes, and everyone in the class is right. I would like to clap for all of you. Very nice. So other causes of low C3. So all of you in your Harrison's textbook, remember there's a table. Causes of transiently low C3, causes of persistently low C3. So the rest causes here are MPGN. MPGN is a cause of persistently low C3. MPGN, membranoproliferative GN. Cryoglobulinemia, it is a disorder seen in adults. Cryoglobulinemia. SLE. Now, why is C3 low? Because C3 is low because C3 is there in the alternative pathway of the complement. All of you know from your MBBS that we have a classic complement pathway, we have an alternative complement pathway. Okay, so in alternative complement pathway, if that is accelerated, C3 is consumed, so C3 is low. So I would say the pathogenesis of post-streptococcal GN is that there is a transient alternative complement cascade activation. Now in SLE, SLE क्या है? SLE में तो both classic and alternative pathways are activated. So in SLE, C3 is low, even C4 is also low. So in SLE, C3 is low, even C4 is also low in SLE. Okay, because both classic and alternative are involved in SLE. So in SLE, both classic and alternative pathways are involved in SLE. So then there is a new disease, new name for MPGN, C3 glomerulonephritis. In hydrocephalus shunts also, and infective endocarditis also. It leads to immune complexes. In infective endocarditis, it leads to immune complexes in our body. So if there are immune complexes, C3 is low. Okay, all of you, cool? Can you just write cool in the chat box? Can you write cool in the chat box? So then I'll take you to case number 2. I have 3 cases to share with you. And I'll now take you to another case, a very common case which I see in my part of the country. And here it is. And I want all of you to tell me the diagnosis based on the history. A 12-year-old boy comes to me with 2 episodes of grossly cola colored urine. So this is a 12-year-old boy who comes to me with 2 episodes of cola colored urine. He has crops of palpable purpura. He has crops of palpable purpura over the lower limbs. And they come in crops, they come and go, they come and go, they come in crops. These are palpable purpura. This boy has joint pains, pain abdomen. He has joint pains, pain abdomen. So diagnosis please first, and then I'll take you to the lab investigations. All of you are right. This appears to be Henoch Schonlein purpura. It appears to be Henoch Schonlein purpura. And now the name is changed. Now we don't say Henoch Schonlein purpura. we say it's called IgA vasculitis. So students, the name has changed now. It's now called IgA vasculitis. Remember, this is the most common vasculitis in children. This is the most common vasculitis in a child. This is the most common small vessel vasculitis. It's the most common small vessel vasculitis in a child. Most common vasculitis in children, most common small vessel vasculitis in children, and the most common leukocytoclastic vasculitis in children. The most common vasculitis, so please remember these three sentences. This is the most common vasculitis in children, the most common small vessel vasculitis in children, the most common leukocytoclastic. इसका क्या मतलब है leukocytoclastic? It means WBCs are invading the vessel wall. Okay, it means the WBCs are invading the vessel wall of the dermis or the kidneys. So remember, WBCs are invading the vessel wall of the skin dermis. Dermis में vessels होती है. Their wall is infiltrated by neutrophils, or even in the small vessels of the kidney. So this was history. Neeraj, it's a small vessel, vasculitis, not shown in purpura. It is written on the screen, all of you. Please note this down. All of you, have you noted this down? All of you, have you noted this down? Can I take you to the examination and lab findings of this patient? Can I take you to the examination and the lab findings of this patient? No, Neeraj. Kawasaki is the most common medium-sized vasculitis in children. You're wrong, Neeraj. Kawasaki is the most common medium-sized vasculitis in children. हमारा क्वेश्चन था overall. So Neeraj, you are wrong. Don't deviate, everyone. Kawasaki is the most common medium-sized vasculitis in children. So can you please write cool in the chat box so that I take you to the examination? On examination, guys, he is hypertensive. And I told you 130/80 is even hypertension for a 13-year-old. This child is a 12-year-old. Let's look at the lab evaluation. On lab evaluation, his urine is full of protein, full of RBCs. C3 is normal. Creatinine is normal. Now, can all of you tell me the complete diagnosis? Okay, this was HSP. मैं मान गया सबकी बातें. But now looking at, this is how we approach a case. On the basis of history, I make a diagnosis. Then I examine, I do some investigations. Now, guys, do you want to improve your diagnosis? Do you want to elaborate your diagnosis? So students, now tell me the diagnosis. You told me HSP, okay, मान गया. Now tell me your complete diagnosis, guys. What is your complete diagnosis? No one is telling, okay. My complete diagnosis here is HSP nephritis. This child has kidney involvement also. So now I will say it is a nephritic syndrome again. This brings me back to nephritic syndrome. Hypertension, hematuria, proteinuria. Triad, hypertension, proteinuria, and hematuria. Can you see? Proteinuria, hematuria, hypertension. It's the typical triad. And Ruchita is right. Ruchita, you're right. This is HSP nephritis. Okay. So all of you, I would like your attention here to the latest criteria. So according to the European Society of Rheumatology, you should know that there are some revised criteria for HSP, और इसको कहते हैं EULAR. What is EULAR? It's a European League Against Rheumatism. It's a European League Against Rheumatism. So the criteria for HSP are palpable purpura and any one of these four. Pain abdomen. So remember, palpable purpura and any one of these four. So EULAR is European League Against Rheumatism. Ritu Sarthak, you are right. And diffuse pain abdomen, predominant IgA deposits, or arthritis, arthralgias, or kidney involvement. So students, every time in your NEET PG, in your Central Institute exam, I can tell you, even in the last NEET PG, there was a question on pain abdomen and palpable purpura with bloody diarrhea. So many students came to me last year and they said, sir, bloody diarrhea kaise ho gaya, sir? Guys, this pain abdomen is basically mesenteric ischemia. It's basically mesenteric ischemia, which can cause bloody diarrhea also, which came in your last year's NEET PG. Okay. So please remember these criteria. They will help you in diagnosing the most common vasculitis. Palpable purpura, diffuse pain abdomen, or predominant IgA deposits, any biopsy, whether it's skin or kidney, arthritis, arthralgias, renal involvement with hematuria, proteinuria. Okay. Okay, cool. Can I take you to the next page? Cool. So kidney, guys, is involved almost in 30 to 50% of cases. So if we look at HSP nephritis, its incidence, it's seen in almost 30 to 50% of all HSP. So at 30 to 50%, okay, incidence. And when do you get the onset of symptoms, onset of kidney involvement? It's usually within, I would say, 6 weeks of onset in 95% of children, and in 99% within 6 months. 99% within 6 months. So all of you, I'll tell you, I'm a pediatrician and I'm also a nephrologist. So I see, I examine the urine of these children. I see these children every week in North India. तो किसी को भी HSP होता है in my state, somehow all these children come to me, and I look at their urine examinations at least for the first 6 weeks, because mostly kidney is involved within 6 weeks of onset of HSP. होना होता है तो पहले 6 हफ्ते में हो जाता है, within 6 weeks. And a small fraction may also have later on. And most commonly, you will see microscopic hematuria plus minus proteinuria. Only 1 to 2% of them can have crescents on the kidney biopsy. It's called crescentic transformation of the glomerulonephritis, which is called a rapid progressive or a rapidly progressive course or a rapidly progressive glomerulonephritis. Okay. Okay. So how do you treat HSP nephritis? Can I take you to the next point? So how do you treat HSP nephritis? Cool? All of you cool? Can I take you to the treatment? Can I take you to the treatment of HSP nephritis now? Next page. So the treatment of HSP nephritis is mostly if someone has, let's talk about treatment of HSP overall. So if he has very severe pain abdomen, we may give oral prednisolone. If he has a lot of nephrotic proteinuria, a lot of proteinuria, edema, nephrotic proteinuria, then also we give oral prednisolone. Only if he has rapid progressive kidney loss, kidney failure, a rapidly progressive course, we will give IV steroids called IV methylprednisolone. Trust me, this kind of presentation, nephritic presentation, is very commonly asked in all exams, whether it's Central Institute exam, whether it's NEET PG. They will take you to these courses for sure. Rapid progressive IV methylprednisolone. We'll do a kidney biopsy here because he's having kidney failure. We'll do a kidney biopsy to look for crescents. And that brings me to the last and the most serious case of the day. Let me take you to the last and the most serious case of the day. And I still remember this child. This child came to me from Uttarakhand, He was a 12-year-old boy. He came to our hospital with breathlessness, cola-colored urine, oliguria. He was on oxygen, and his BP is 140/90. Okay. So all of you, can anyone tell me based on the history, what is my diagnosis here? Anyone in the class? You have a child who is puffy, cola, urine, oliguric, hypertensive. Of course, it's a nephritic syndrome. But why is he dependent on oxygen? Can anyone in the class tell me? What would be my differential diagnosis here in a child who comes to me with the typical nephritic picture, cola urine, hypertension, okay, edematous, you are very, very smart children. I like it. So yes, but let's start from the common things first. common things would be that this could be, fluid overload. इतना edema हो गया, pulmonary edema है, he is dependent on oxygen, maybe pulmonary edema. Okay, and very nicely said by Tanu, Motashim, Yamuna, Ashmita, and Neeraj. Lovely, Richard Sharma. I'm very happy with you, and even Shubhangi. Hemoglobin is 5. So when I saw this child, this is a real child, and I still follow him. It's been more than 5-6 years. So his hemoglobin is 5, creatinine is 2.5, urine is active, full of RBCs, RBC, CAS, proteinuria. So guys, would you like to? Okay, let me show you the X-ray. Here's the X-ray. Here's the X-ray, guys. Can you see some fluffy? Can you see some fluffy opacities? Bilateral lower lobes. I can see a lot of fluffy opacities. Bilateral lower lobes. This could be edema. However, hemoglobin is 5. He is dependent on oxygen. All of you are right. But I still got a CT chest done to look for pulmonary hemorrhage. Okay. अरे hemoglobin कम है तो कहा गया he bled somewhere, guys, and this child bled into his alveoli. This child, and this is the CT chest showing both lower lobes have pulmonary hemorrhage. English में कहते हैं DAH. This is called diffuse alveolar hemorrhage. Okay, so I got a CT chest to look for diffuse alveolar hemorrhage, and these are real pictures. I have not taken from Google. These are all my patients. So diffuse alveolar hemorrhage. So here's my diagnosis. My diagnosis here is a nephritic syndrome, and very nicely told by Shubhangi, with diffuse alveolar hemorrhage. Okay, very nicely told by Shubhangi. It could be a pulmonary renal syndrome. There are many differentials to this. This is a nephritic syndrome, and I would like to add here, guys, this child has a creatinine of 2.5. He is rapidly, progressively deteriorating kidney function. He is rapidly, progressively losing his kidney function. So my clinical diagnosis is nephritic syndrome. His hemoglobin is 5. He bled into his alveoli, diffuse alveolar hemorrhage, and rapidly progressive glomerulonephritis. Next day I did a kidney biopsy, and this is his kidney biopsy. Can you see crescents? So all of you, whenever you have a patient with RPGN, rapidly progressive deterioration, you have to do a early kidney biopsy to look for crescents. And can you see the crescents here, guys? Can you see the crescents here? What are crescents? Crescents are proliferation of the parietal epithelial cells. Crescents are proliferation of the parietal epithelial cells. Okay, in the glomeruli we have visceral epithelial cells, parietal epithelial cells. So crescents are proliferation of the parietal epithelial cells. And very nicely told by someone in the class, Shubhangi, Richard, Tannu, Yamuna, Ashmita, Neeraj. Dekho, all of you, good pastor syndrome is very, very rare in children. But in my institute, we have a test. We have a test called, it's called a LIA. We have a LIA, line immunoassay. And by single test, we can do all of these three. So I got his anti-GBM checked. It was negative. He was positive for C ANCA. C. ANCA. So C. ANCA is basically an immunofluorescence, and we look at that they are antibodies against the cytoplasmic anti-nuclear antibodies. Okay, which is actually an antibody against proteinase 3. So remember, C. ANCA is actually an antibody against proteinase 3. Okay, C. ANCA is an antibody against proteinase 3. C3, C4 were normal. So we found that he had ANCA associated. So this is my diagnosis in this patient. He is a rapidly progressive glomerulonephritis. He is rapidly losing his kidney function. He has ANCA associated vasculitis and diffuse hemorrhage in his lungs. Okay. So students, why am I talking about this? Because before I finish off my class, I want you to know what is RPGN. Before we stop, I want you to know what is RPGN, because this clinical vignette always comes in your exams. It is nephritic syndrome plus rapid deterioration of kidney function. Nephritic plus rapid deterioration of kidney function. And mostly on the biopsy, you will see crescents. Nephritic syndrome plus rapid deterioration of the kidney function. On the biopsy, you see crescents. Okay. Santosh, crescents are proliferation of the parietal epithelial cells. Okay. So I just want you to know that RPGN is of 3 types. We do early kidney biopsy because we want to look at whether it is an immune complex glomerulonephritis. So are these crescents immune complex? I'm looking for crescents. Immune complexes are seen in IgA, HSP, SLE, or it can be an anti-GBM disease. So where you will see linear immunofluorescence. So anti-GBM, where you see linear deposits of IgG and C3. Or it can be a quasi-immune. Quasi matlab there are no immune deposits. Quasi-immune, which is usually seen in microscopic polyangiitis, or Churg-Strauss syndrome, for which you need to do an ANCA. So now all of you, can you see? We do an ANCA here. We do anti-GBM levels here. We do SLE, ANA levels, C3, C4. We do to look for every patient who presents to us with a nephritic syndrome with a rapid loss of kidney function. Okay. Okay, all of you. Why are we so concerned about RPGN? We are concerned about RPGN because number one, we have to start early IV methylprednisolone. So we are concerned here because I want to start him on early methylprednisolone. It is high dose methylprednisolone pulses, 3 to 6 doses, followed by IV cyclophosphamide, monthly doses, monthly for at least 6 doses. And why am I concerned about RPGN is because There are some specific indications where we have to start early plasmapheresis. Plasmapheresis matlab we remove the plasma and we give this patient fresh plasma. We remove the plasma, we give him fresh plasma. And there are some two specific indications of plasmapheresis. Number one is anti-GBM disease. In anti-GBM disease, we remove the anti-GBM antibodies. We remove the anti-glomerular basement membrane antibodies. We also do plasmapheresis in ANCA-associated vasculitis, which is requiring dialysis. If this needs dialysis, I will do a early plasmapheresis. And the last is, of course, diffuse alveolar hemorrhage. Even if there is no kidney problem, diffuse alveolar hemorrhage in a ANCA vasculitis is a class 1 indication for early institution of plasmapheresis. Diffuse alveolar hemorrhage with ANCA vasculitis is a definite indication. There's a lot of evidence behind this. So you should do early plasmapheresis in diffuse alveolar hemorrhage, ANCA vasculitis. If ANCA vasculitis requires dialysis, also you should do early plasmapheresis. So these children require steroids with plasmapheresis. Okay? Okay, students, cool. So can I just summarize what we read today? Cool. Can you just write all of you cool on the chat box? So students, today what I wanted all of you to know in this grand round was that nephritic syndrome is common. So please, you should know what is nephritic syndrome. It is common when we see patients. The most common cause of nephritic syndrome is post-infectious, especially post-streptococcal. Okay. Now things have changed. Don't think that, even now, as we are progressing, we are still seeing, however, it is less common in America, it is less common in the developed world. Outcome is good in children, not in adults. So in children, 95% will improve of post-streptococcal. And today I am here to tell you guys that there is a specific condition called RPGN, which is a medical kidney emergency, requires early steroids, early kidney biopsy. Again, immune complex is the most common, and these children need early aggressive therapy. Otherwise, they will die. And I am telling you about that child from Uttarakhand. We started early plasmapheresis, early steroids in that child, and he's completely fine. I still see him. We are slowly reducing his drugs over the last 5 years, and he's completely well. And everything is good in that child. So it's because we thought about this. Why is hemoglobin 5? Why are we having fluffy opacities? We thought about early diffuse alveolar hemorrhage in that patient. Okay, so that was all about the clinical cases which I wanted to share with you, students. Dr. Sachin will be showing you a mania patient today at 10:30. So all of you, how was your class today? Do you have any questions? We have 5 minutes and then you can go to the psychiatry room to join the psychiatry class. So all of you, you can ask me queries here. So room is open for queries. So we'll take queries for the next 5 minutes and then we'll stop. So how was your session? Did you enjoy? These are difficult patients, but it's important if you can recognize them early. Doubts? Anyone? Doubts? Case 3, Shubhangi, was rapidly progressive glomerulonephritis with ANCA vasculitis with diffuse alveolar hemorrhage. He had alveolar hemorrhage in both of his lungs. So it was RPGN with diffuse alveolar hemorrhage. Santosh, yes, crescents are proliferation of the parietal epithelial cells. Fundus we do because hypertension, even acute hypertension, can have features, Richard, of you may have retinal bleeds. So every hypertensive case, you should do a fundus. Okay. So of course, in renal vein thrombosis, also you can have hematuria, but that's out of our context today. Hyperlipidemia can also be seen in these patients, but that's not a part of our criteria. Parul. So you guys take a 5-minute break and we'll come back with a clinical grand round on psychiatry. Thank you. I'm always open for suggestions, and if you want to ask doubts, this is my email address, sitsdoc@gmail.com. On Facebook, I'm on, you can tag me at PDF for PG. On Facebook, I'm on PDF for PG. Okay, that's my email, sitsdoc@gmail.com. On Facebook, you can tag me at PDF for PG.